While she's getting my slides up, I just wanted to tell you how excited I am to be here. It's really great to see patient groups and great to see communally how well you're doing compared to when we used to go to patient meetings 20 or 30 years ago. I also want to commend both Cindy and Aviva on how well this meeting has been going. So they asked me to speak, this seems to be my topic every time, but again about Gaucher disease and Parkinson's disease. Some of you may have heard before, some of it is a little bit new. I like recently to begin my talks with this quote. I live in a small house, but my windows look out at a very large world. And my small house for the last 35 years now has been the house of Gaucher disease, where I've been studying patients. And I don't need to define Gaucher disease for any of you, but by studying it, I've had a unique window into a common complex disorder, Parkinson's disease. And we've been studying this relationship now for almost 20 years. At the beginning, people didn't believe it. And now the story has shifted quite a bit. And we use many different approaches to trying to better understand the link. Though to me, there's still many, many question marks. So some of the questions I'm sure that you guys are thinking about when you hear that I'm going to talk about Parkinson's disease is, isn't having Gaucher disease enough? Am I going to get Parkinson's disease too? What more do we need to worry about? And I'll try to address some of these as I talk. I use the word GBA1 as the gene, and GCase, or glucocerebrosidase, is the name of the enzyme. So as you well know, there's lots of different symptoms seen in Gaucher disease. And sometime about a decade and a half ago, Parkinsonian manifestations got added onto the spectrum. I'm not even really sure that the Parkinson's is necessarily a part of Gaucher disease, though interestingly, one source of new patients with Gaucher disease has been the Parkinson's disease clinic, where they've begun screening for mutations, and they've identified individuals in their 60s, 70s, 80s who never knew they had Gaucher disease. So Parkinson's disease, unlike Gaucher disease, is a common disorder. It affects about 2% of the population that's aging over 65 years. It's more frequent the older you get. There's about 40,000 new cases per year in the United States. It affects about 1 million people. And it seems like the incidence is rising compared to other disorders. There's clearly contributions of both genetics and environmental factors in Parkinson's disease in general. This cartoon shows some of the clinical features that many of you will recognize of Parkinson's disease. By definition, it's clinically and pathologically defined. There isn't a blood test to tell you whether you have Parkinson's disease. The symptoms include, you have to have slowness of motion and at least one of the following: rigidity, a rest tremor, or instability, postural instability. I also will use the term Parkinsonism, and that's describing the motor features of Parkinson's disease. But there can also be non-motor symptoms, and these include a loss of the sense of smell, constipation, urinary problems, and cognitive changes. And then there's another disorder called dementia with Lewy bodies that is somewhat related, but it tends to have more severe cognitive deficits, and it progresses more rapidly. So for me, this story began back in 1996 with a single patient who had Gaucher disease and an early onset Parkinsonism. First, we thought it could be a coincidence. We then talked to colleagues and eventually identified others, wrote them up, and at the same time started taking close family histories of our patients with Gaucher disease. And it seemed like there were more cases of Parkinson's disease in relatives of our Gaucher patients who were heterozygotes. Then, make a long story short, we and others started looking at patients first with Parkinson's disease and also with Lewy body dementia, and we found an increased incidence of GBA mutations. And we eventually put together a large international study and determined that patients with Parkinson's disease were over 5 times more likely to carry a Gaucher mutation. GBA1 is now considered the most common genetic risk factor for Parkinson's disease and for dementia with Lewy bodies. And what I found was interesting was that when you now Google or do a PubMed and you put in GBA1 or glucocerebrosidase, you find about 5 times more papers about Parkinson's disease than you do about Gaucher disease. It's a field that's just exploding. And just in the last 4 years, there's been almost 600 papers on this connection. Why is it important? Because this finding has really directed attention of the role of that organelle that we know so well, the lysosome, in many different neurodegenerative disorders. Why this Gaucher story has been so exciting to the Parkinson community is when we find a gene for a complex disorder, at least it gives us a starting point. And here the starting point was whether lysosomal pathways have something to do with Parkinson's disease. And in fact, now through many different studies, there's lots of genes that have been associated with Parkinson's disease, but almost half of them fall into either lysosomal or lysosome-related pathways. Now this slide is really important for you guys, so I want to talk you through it a little bit. This just indicates that people who have GBA mutations are at increased risk for Parkinson's disease, but it doesn't mean you're going to get Parkinson's disease. In fact, it may increase your risk 3 or 4 or 5 or 6 times higher than the general population. But if you look at this survival curve, this is showing patients at different ages. And by the time you get to age 60, patients that either have 1 or 2 GBA mutations are about 3 times more likely to have Parkinson's disease compared to the general population. But let's look at this whole list. So 90 to 95% of you won't go on to develop Parkinson's disease. It's what we call a risk factor, and it's really confusing to us to determine what affects this penetrance. Why do some people with mutations get Parkinson's disease and some people don't? Well, in general, this association, even though it might give you something else to worry about a little bit, it also has a silver lining because many different Parkinson's disease groups are now funding all kinds of research on glucocerebrosidase, and they're looking for therapies that are going to increase glucocerebrosidase. And there's a ton of money in this. There's the Michael J. Fox Foundation. There's this project ASAP that's been funded by Sergey Brin, where he gave $2/3 of $1 billion over 10 years for research in general and Parkinson's disease. And many of the groups that he's funding are interested in GBA. Also, most of the big pharma companies now have programs in GBA. Roche and Merck and you name it, Lilly, they're all now interested in GBA. The other thing that for me personally was, the other thing I wanted to mention was Lorna mentioned this, but just in June of this year, there was a conference just on GBA Parkinson's disease in Montreal. Aviva was there. There were more than 200 participants from 135 institutions, including presentations from over 15 pharma companies. So this is just a lot of attention. And for me personally, it was exciting because this year's Breakthrough Prize in Life Science, which is kind of like the Oscars of science, was awarded to Tom Gaucher, myself, and Andy Singleton for finding the most common genetic causes of Parkinson's disease. I'm not trying to toot my own horn, but it wasn't because I was a Gaucher investigator. It was because Parkinson field feels that that's so important. But I do want to mention that if you want some nice entertainment, just Google YouTube Breakthrough Prize 2024 in the ceremony. It was just tons of fun because it was a bunch of nerdy scientists and all these Hollywood movie stars in their fancy clothes doing all kinds of goofy things. So back to business. So for over 15 years now, we've been studying patients with Parkinson's disease to see if we could find early features in an at-risk population. Grisel Lopez, who's been working with me, has worked on this. Aslam did for a few years early on also. We recruit patients that have Parkinson's disease and Gaucher disease, and we also recruit Gaucher carriers that have Parkinson's disease. And so that's our PD group. And then in parallel, we've been studying an at-risk group that many of you here in the audience have participated in, where we're looking at patients with Gaucher disease who might have a family history of Parkinson's disease or who are older than, 60 or so and don't have Parkinson's disease. And we're looking at also carriers with a positive family history. When they come, they undergo a gamut of clinical studies. And I've shown this slide many times, and people are probably saying, well, you've been doing the study, isn't it going to change? Well, this is taking a long, long time, and I'll explain to you why. But when you come in, we do a neuro exam, we do a physical exam, we do neuropsych testing, we test your ability to smell things, we do all kinds of questionnaires, and we've done some imaging studies, including PET scans and transcranial sonography, which is an ultrasound of your brain. So during this 15 years, we've seen about 155 patients. This has included 30 with Parkinson's disease and 125 without, and 92 who had Gaucher disease and 63 HETs. Some of them have been seen once. Some of them, like a few of my friends here in the audience, have been seen about 8 times over the last 14 years, and maybe even more. For the longest time, there was a single neurologist, Grisel Lopez, and a single neuropsychologist who's now retired. We did a PET study for over 10 years, and for about 15 years, we've been doing this transcranial sonography. So what's the bottom line? Well, in our 30 patients that have Gaucher and Parkinson's disease, we find that they have many clinical and pathologic findings that are similar to just run-of-the-mill Parkinson's disease, though some have the features, both pathological and clinical, that are characteristic of dementia with Lewy bodies. Most respond pretty well to levodopa, which is the regular treatment for Parkinson's disease. In general, our patients with Parkinson's disease had an earlier onset of Parkinson's disease with the mean age of about 49. We've had some that were quite young. They tend to more likely to have a positive family history. Non-motor symptoms and the sense of smell are often affected. Progression tends to be faster, and in some cases there's more cognitive dysfunction. But I always like to say, not always. And in fact, we see many different exceptions. And I'm always uncomfortable when people get up here and say, yeah, GBA Parkinson is the most rapid, severe form of Parkinson's disease. Maybe, but we certainly see some patients that have had Parkinson's disease for 30 years and haven't had cognitive findings. And the rate of progression doesn't seem to be all that related to genotype. So what about the studies that we did? Well, we did these PET scans to look at your dopamine. And you can appreciate that if you look at these two panels, they look very much the same, and they are very much the same. Patients with regular Parkinson's disease and with GBA Parkinson's disease have the same findings on PET scan. What's interesting is that the patients that we imaged multiple times, we didn't see any difference in the amount of dopamine they had over time, which is really good news for you in general. We also did these measurements with ultrasound of the brain, and we found that people who had Parkinson's disease did have larger areas of echogenicity, but those that didn't have symptoms didn't seem to have any changes on ultrasound. So it looks like neither of these modalities are going to be predictive of who's going to go on to develop Parkinson's disease. We also tested the sense of smell. We published this, but we had about 117 participants. We had this 40-item sniff and smell thing that kind of is annoying, but you have to scratch and identify what the smells are. Some of our patients, about half of them, did at least 2 and up to 6 times. And what we found was at baseline, the patients that had Parkinson's disease had a less good sense of smell. The at-risk group tended to be scattered, with a few with a bad sense of smell, but the ones that we followed over time didn't seem to get worse over time. So again, this doesn't seem all that predictive. We also did these questionnaires and did neuropsychiatric assessments. So these were just the basic IQs. As they say in Lake Wobegon, our patients are all above average in all the groups. So we didn't see any significant difference at baseline in cognition. And we really only saw deterioration in the patients that had clinical Parkinson's disease. But the at-risk group showed no neurocognitive differences over time. We did these questionnaires for different motor symptoms. And here, in the at-risk group, we saw no consistent progression to abnormal scores over time. Well, this has been a hard study. I mean, we spend a lot of time with each of you each time you come to us, and it's like, should we even continue if we're not finding anything? Well, we are still continuing, but we're probably more focused. As we've told you in the past, we'll see any patient once, but I don't think that it merits bringing people back every year because we are not seeing changes that quickly. So in summary, in our at-risk group, 125 patients that have been seen over this period that includes 75 patients with Gaucher disease and 50 heterozygotes, all of whom are over age 50. These have included, most have a family history of Parkinson's disease, often a sibling or a parent. We debate back and forth. I really think there was really only one person out of that whole group that converted to Parkinson's disease during the period that we've been following them. We didn't see any PET scan studies over time. We didn't see changes on transcranial sonography. Sometimes the smell test was slightly lower in some of the Gaucher patients, but it didn't seem to deteriorate over time. 4 of our patients have passed away, and we did autopsies, and we didn't see any pathologic signs of Parkinson's disease in their brain. And again, only 1 patient has developed Parkinson's disease. So we can say we need longer follow-up, perhaps. We might need a larger trajectory, perhaps. Perhaps this is the way it is. It's clear to me that most patients are not on a Parkinson trajectory, which makes it a little hard, as you heard from Lorna, about trying to identify an at-risk group that would benefit from early treatment for Parkinson's disease, because I'm not sure that many of you are going to go on to develop Parkinson's disease. Because this is really, having the mutations just a risk factor. Having 2 Gaucher mutations is the cause of the disease, but for Parkinson's disease, there's clearly other factors, and our challenge right now is to try to figure out what those other factors are. And in addition to these clinical evaluations, in parallel, we've been using different genomic approaches. The time's now right to be able to do all kinds of things with DNA and RNA and proteins that we were never able to do. So one approach that we've had is that we've been recruiting sibling pairs that have Gaucher disease where only one sibling has Parkinson's disease. So again, both brothers or sisters have Gaucher disease, only one developed Parkinson's disease. We've been seeing those patients as often as we can, each time they have the whole battery of evaluations, and we've done whole genome sequencing. So far, we haven't seen any indications of Parkinson's disease or PET changes in the non-Parkinson's SIB. But what's really important is each time they come, we bank plasma, serum, RNA, fibroblasts, because we think that these sibling pairs may help us identify either other risk alleles or other protective things. So for us, it's just as valuable to study patients, the sibling that doesn't have Parkinson's disease as the one that does. One thing we've used these lines for in recent years, and this was the work of a really talented postdoc, Ellen Hertz, is that she took skin fibroblasts from both members of the pair, and she made these induced pluripotent stem cells. So for each of the pairs, she reprogrammed the iPSCs, and she made 2 kinds of neurons, dopaminergic neurons and cortical neurons, did appropriate quality controls, and then went on to try to phenotype the lines from the patient, the sibling with Parkinson compared to the one without. To our surprise, we really didn't see any differences in enzymatic activity nor glycolipid storage in the dopamine neurons and the SIB pairs. There's been some interesting findings with RNA-seq, but we're still continuing with that. The other project that Ellen had was in line with what we just heard of from Dr. Mistry, was that some patients over the years have generously arranged for us to get brain donations when they died. And we were able to do this same kind of single cell analysis that Dr. Mistry showed you in the mice and some of the samples of patients with Gaucher disease with and without Parkinson's disease, and we're completing that analysis. Well, this is a slide that I just took in the audience when I was up in Montreal, just to show you that there is a lot of attention to therapies for GBA Parkinson's disease. Apparently there's 29 clinical trials online. There are some phase 1, phase 2, and phase 3. 9 of them are chaperones, 8 with Ambroxol. There's 6 different companies that are starting gene therapy protocols, 5 different ERT type of protocols, things like giving ultrasound to try to break down the blood-brain barrier, and there's a few others. The challenge is to get the enzyme to the brain. As you guys know, the Gaucher drugs that we know don't cross the blood-brain barrier. So there's been lots of attention to other different strategies, like a substrate reduction that didn't seem to work, other ways to get the enzyme into the brain. And what we've been working with on our group for some time now has been glucocerebrosidase chaperones, and we've begun to look at gene therapy to the brain. So the chaperones, as you heard, is a gene-modifying therapy that promotes the glucocerebrosidase that's misfolded to recover, and when it gets to the lysosome, things can stabilize and it can make your enzyme work better. So for some years we've been doing this project, and I've been showing it, and we kept on running into roadblocks because we just didn't have the right assays. As Oslo mentioned, when you measure enzyme activity, it's not a very reliable tool. And the reason is because you take a sample from somebody, and it's a sample of the whole cell, but it doesn't tell you what's happening in the lysosome. So in the last few years, we really have made progress in that we have made tools that, one, allow us to see what's actually happening in the lysosome, and 2, we've made these constructs that allow us to tag the misfolded protein, and we can use that in different high-throughput screens. So we have a paper that, I won't go into the details, but will be coming out in the next week or 2 in PNAS that shows how nicely this work through is right now, and we're hoping that it will lead to some materials that can eventually become drugs. So these are 2 of the assays that we're now using to track what's actually happening in the lysosome. And then we have a very early program in collaboration with Chuck Venditti at NHGRI, which is gene therapy, which I think could have relevance to early neuronopathic Gaucher disease and potentially Parkinson's disease. We've heard a lot about gene therapy. I won't go into that in detail. Our strategy is somewhat different with different constructs. But what shocked me was when we used the mouse model that people know, which essentially, if you have no glucocerebrosidase, the mice die before birth. But there has been a model where you can knock out the enzyme every place but the skin. And these mice generally are born and live for about 2 weeks and then have seizures and die. But when we injected gene therapy, to my astonishment, we've been able to keep these mice alive now almost 14 months, 15 months, and they breed and seem quite normal. So I wasn't really going to go into gene therapy, but these findings are pretty exciting to me, and we'll see what happens with this project. So my take-home messages are that variants in our gene are a risk factor for Parkinson's disease, even in carriers, but most patients and most carriers will never develop Parkinson's disease. Learning more about this connection will improve our understanding of both disorders, and new drug development for GBA Parkinson's disease may be beneficial for patients with Gaucher disease. How to contribute to this work? Welcome to get involved in a study. always happy to take participants in ours. Michael J. Fox has the PPMI, which is following patients with glucocerebrosidase mutations. And you just heard the Canada approach. There are many other research centers. Both patients with Gaucher disease and carriers with and without Parkinson's disease are very valuable for this type of research. I always like to mention that you might want to consider tissue donation at death. We have very few of these precious samples, and they really are helping us a lot. Keep up to date, look at clinicaltrials.gov. And again, if you were ever seen at the NIH, like past in the 80s or 90s, we'd love to at least talk to you, because the consents that you signed for research back then are not relevant to what we do today. And especially if you were seen as a child and now you're an adult, we'd like to explain what we're doing and get your permission to continue to use the samples that you so generously donated. So I hope I can show you that our studies of Gaucher disease give us this nice window into a different complex disorder, which hopefully will bring us to therapies for both disorders. So I want to acknowledge my team that's done all the work, my collaborators at NCATS, some of the Parkinson teams that I've worked with, collaborators around the world, but always I'd like to give my special thanks to patients, family members, caregivers, and referring physicians that make our work possible. Thank you.